Good afternoon, everyone, and welcome to the Obesity Collective webinar in honour of World Obesity Day 2025. We're thrilled to have you all join us today as we come together to raise awareness, share insights, and continue our global efforts in addressing the pressing issue of obesity. My name is Dr. Kimberly Norman, and I'll be your host for today's webinar. Before we dive in to this incredible session with all these amazing experts, I would like to just go through a few housekeeping reminders to everyone. This session is being recorded, and the recording, along with the presentation slides, will be shared and available for you to watch later. We have a great lineup of obesity experts today. All the panelists will present their work, and then we will do the question and answer session afterwards at the end. So please feel free to use the Q&A feature on your screen to submit questions during the presentation. And if you have any questions for a specific panelist, please include their name in your question and we'll do our best to answer it for you. So without further ado, I would like to bring on our first speaker of the day, Louise Bauer, who will do our welcome and acknowledgement to country. Thank you.
Good morning, good afternoon, and possibly good evening to some people, depending upon where you are joining from. Just as we start, I'd like to acknowledge the traditional custodians of the lands on waterways on which we are all meeting across this beautiful country of ours. I want to acknowledge Aboriginal elders of the past and the present, and to welcome any Indigenous people, any Aboriginal people, Indigenous people, if you're coming from Canada, who are joining us here today. We acknowledge your long custodianship of this land. We acknowledge that Aboriginal and Torres Strait Islander people were our nation's first scientists and had complex ways of caring for their community. Thank you.
Thank you, Louise. I've finally made it in. So, thank you.
Hi, Stephen. Welcome. I'll just spotlight you so everybody can see you. Go for it, Stephen.
Well, I'm sorry about the muddle. Trying to make it onto Zoom, which wasn't in the end altogether straightforward. So thank you, Kimberly, and thank you, Louise. I gather from that you've provided us with acknowledgement of country, and I too would like to pay my respects to the traditional owners of the lands upon which we're meeting, each in our different locations. I'm here on Gadigal land in the Charles Perkins Centre, and I would also like to acknowledge Charles Perkins, and Aranda man and Kalkadoon man, who has made a great difference to our Indigenous Australian, the standing, the status, and the celebration of our First Nations peoples. So acknowledgement to Charles, as well as elders past, present, and emerging of the Gadigal people and all other nations upon which we're meeting. So this is our 6th Obesity Collective World Obesity Day seminar, and it's my role to welcome you here. I'll do that briefly, given that I'm somewhat delayed. I'm Executive Director of Obesity Australia, which is the governing body for the Obesity Collective, and also Academic Director of Charles Perkins Centre. And the World Obesity Day event, this being the 6th, is held annually on the 4th of March and serves to promote a better understanding of the prevention, treatment of obesity while amplifying the lived experience. And this year, the theme of World Obesity Day is changing systems, healthier lives. And the emphasis really is on the need to shift the focus from individuals to systemic change, whether that be in health, in government, in the food system, in the media, or in our built and living environments. We need to address obesity through addressing and reforming some of these systems which are failing to support a healthy weight. And in short, I guess we must fix systems, not blame individuals. So that's really the theme for not only World Obesity Day, but for today's event. And as we all know, of course, tackling obesity has many other benefits, and that include, or those include, reducing the risk of many other chronic diseases like diabetes, heart disease, many cancers, not to mention improving mental health and quality of life. So with that, welcome, and I'll hand over belatedly, and sorry I was late, to Professor Tim Gill, Director of the Obesity Collective, to introduce the Obesity Collective's principles and to discuss the added focus on equity in this year's theme. Over to you, Tim.
Yes, thanks. Thanks, Steve, and welcome everybody. Most of you, or a large proportion, you're probably well aware of the Obesity Collective, but I just wanted to explain who we are and where we're coming from those that may be new to us. As the term suggests, we are a collective. We are a wide coalition of individuals and groups and organisations that are working to improve the management and prevention of obesity. So the collective really is just a way of bringing together a very disparate range of voices with a common focus. And that common focus is to promote evidence-based action on prevention treatment. And particularly, we have a particular focus on stigma, which some of our speakers will be addressing later, because we see stigma as such a barrier to improve prevention and management action. So next slide, please. So as Steve pointed out, we have, as well as dealing with the World Obesity theme, which is changing systems to improve healthier lives, we've added an extra dimension because it's such an important issue for the Obesity Collective, and one we see such a huge barrier in Australia, and that's improving equity in obesity through changing systems to create healthier lives. And hopefully in the speakers that follow me, you'll hear about situations that have created inequity in obesity, and followed by speakers who are going to be talking about how we're going to deal with reducing that inequity. Inequity is obvious to anyone who's been dealing with issues around obesity. So you see huge inequalities in the prevalence of obesity. So if you just look at this data from 2018, it just compares some of our wealthier suburbs in our major cities to some of our less wealthier regional areas. And you can see huge inequality in terms of the prevalence of obesity. Next slide, please. And as Steve pointed out, it's important that we not look at those figures and say people in those areas need to be doing more to prevent themselves from getting obesity and to manage their own obesity. Whilst it's obviously true and people in those situations understand that, their inequalities in obesity prevalence are being driven by inequities in the systems that serve them. I'll have to complain about the system we had today in terms of setting up this webinar, which is an example of a very poor system. And that's exactly what people in these areas that suffer high rates of obesity are dealing with as well, except their systems are much more important and have a much more profound effect on their life. So they're dealing with poor planning, they're dealing with poor provision of services, they're dealing with financial stresses, with a whole range of issues around employment, around transport, around a whole range of issues that are beyond their control. And that's why in this particular webinar, whilst we want to focus on changing those systems, we want to focus on changing those systems to reduce the inequity that they create as well, which we see within the Obesity Collective as one of our most important objectives to improve the health and wellbeing of every Australian. So I'll pass on back to Kimberly, who's going to introduce Diane.
Thank you so much for that, Tim. I'd like to introduce Deanne Minicon. I'll leave far away, Deanne.
Thank you very much. Yeah, Deanne Minicon. I'm both from the Torres Strait Islands and both Aboriginal, so Erup, which is Darnley Island, and Gorang Gorang, which is around the Bundaberg region in Queensland. I'm one of the group executives for Aboriginal engagement with Diabetes Australia, and I'm coming from the lands of the Tarablang Bunda people. When we talk about obesity or address the issues of obesity for Aboriginal and Torres Strait Islander people in Australia, we have to consider a few things, and that's Australian history, our own history, and the impact that's had on Aboriginal and Torres Strait Islander people, the environments where we live to support those healthy lifestyles, and what strengths our communities are currently living with. So prior to colonisation, we know we were healthy people. As Louise mentioned in the acknowledgement, we were the first scientists, but we were the first dietitians, the nutritionists, the health professionals in the world. So past policies placed on Aboriginal people have interrupted those skills. But they've also interrupted our food supply and food systems, our culture, and how that knowledge is passed down to our next generations. So Aboriginal Island people had restrictions placed on access to their lands and their natural resources since colonisation. And so this has impacted on hunting and fishing and access to those nutritious foods and food sources for some communities across Australia. Our original healthy lifestyle have been replaced with Western style foods that are high in sugars and fats. We know that up until the 1960s, and in Queensland it would have been about the 1980s. Indigenous people were on missions and farms and were paid often in rations of the worst kind. So our white flours, our refined sugar, our salts, our teas. So that's really influenced, and it still carries on today, how we use those as well, those ingredients as well in the foods that we eat today. So you can see the negative impacts that this has had on our people, both physically, socially, emotionally, cultural, and spiritually. So the outcomes include the most rapid growth rates of obesity, disability, chronic illness, and physical distress. Next slide, please. So access to affordable nutritious food is an ongoing problem in many remote communities. Can we go to the next slide, please? And so look, I'm going to go off script here, and I did have a beautiful script, but one of the things that we need to take into consideration when we're thinking about obesity and how we can create healthier lifestyles for people are the environments that people are living in. You can see in these images, there's issues around roads, so that's main roads, transport, when there's weather events, climate change. It impacts on whether food supplies are becoming to communities, particularly those remote and rural communities. Access to safe pathways for walking, whether that's pathways, whether that's lighting, whether that's security, or whether that's animal management, and so something that the council needs to deal with. When we used to deliver a brief intervention many years ago in Queensland Health, we used to visit these remote communities and say, you tell us to walk, but one of the problems when we go to walk is the animals, and not just the dogs, but the bulls and the snakes and the kangaroos and those sorts of things that restrict that activity in those communities for some people, not all. And also that water quality. So while we say drink plenty of water and less sugary drinks, what we don't understand is that a lot of these communities, there are issues around water supply and water quality and the water taste and what the water looks like and what the water smells like. And this just doesn't mean that we have to drink this water. It's about food safety issues too, when we're asking people to wash their vegetables before they eat or their fruit before they eat. So we need to take consideration of all these bigger social determinants that impact on our health and well-being in terms of obesity. We're also looking at the food supply in stores, and I've experienced it myself up in the Torres Straits, where the barge came in, dropped the fruit and vegetables off, and I think that went in a few days, and the barge wasn't coming back for 2 weeks. So while we say eat plenty of fruit and vegetables with these beautiful programs that we develop, we don't actually take into consideration some of the challenges that people have in accessing healthy foods and fresh food supply. So we need to kind of think about these things. Now, you know, this is having a huge impact on our communities, and particularly for now, it's really impacting on our young people. We're seeing people, the increase of type 2 diabetes in young people across the top end of Northern Australia. That's, you know, being diagnosed with type 2 diabetes at the age of 4. Now, this is unacceptable and it's getting worse, and we need to do something urgently about it. And then it'll also impact on rates of obesity as well. Next slide, please. So we talked about all the challenges around food insecurity, the diets, but we also have to understand that in Aboriginal Islander communities, there's some really beautiful strengths that we have, and a lot of us still have access to our cultural foods where they are available. We encourage people to access those as much as possible. We have eaten these foods for many years, but one of the things that we need to understand is sometimes when we come in with our own Western value ideas around how we actually manage that food or treat that food before we eat it, you just have to talk to community about some of these things. So for example, dugong or sea cow, when you cut that up, the fat from there, when they boil it and they create the dugong oil, is actual medicine. So when we're asking people to cut fats off meats, we need to think about what that actually means for people's health and well-being and spirituality as well as there's a cultural process and protocol around when they do hunt and gather for food as well. But the food is not just medicine, it's cultural practice, it's learning language, it's learning connection to communities, all those sorts of things comes in there. So I guess where I'm coming from is use the communities' knowledge and histories and strengths of that community when we're working with communities around addressing obesity. Take those that celebrate their culture, acknowledge the histories and acknowledge the challenges that they face as well. But we do have a lot of strengths in those communities. Right across Australia, not just in the remote communities, but also in those urban and regional areas as well. Thank you.
Thank you so much, Deanne. I'd like to introduce the next speaker. We have Dr. Blake Lawrence.
Yes, hi everyone. Thank you for the opportunity to speak today on World Obesity Day. I think this image here is quite a juxtaposition to the beautiful images that were presented before by Deanne. But yeah, I'm going to be speaking about the socioeconomic drivers of obesity, and it's aligned with the research that I do at Curtin University, based in Perth, Western Australia. So yeah, next slide, please. So starting off with the economic drivers, so there's substantial research that shows that economic hardship is one of the strongest predictors of obesity. So people living with economic hardship, sort of in more of those lower socioeconomic environments, they often live in what we call sort of an obesogenic environment. So this means that they frequently have less access to spaces or environments where they can participate in physical activity. So whether that is parks or recreational facilities, when it comes to, say, I guess, even if they, really want to participate in physical activity or different sporting activities, they're just living in an environment that limits that ability to do so. There's also greater access to calorie-dense, nutrient-poor food, which is just a complicated way of saying junk food. And then there's often less access to high-quality healthcare services as well for people that are living with, economic hardship. And importantly, I think it's really important to emphasize the final point here is that while there is often less access to, physical activity, say healthier food, and higher quality healthcare services, there's often more urgent priorities for a lot of people living with economic hardship, whether it's, their long work hours, raising their family, needing to pay their bills, that may actually come before some of these other lifestyle, say, decisions or options they may even be able to think about. So that sort of broader underlying economic hardship can really have an impact on their ability to even consider, lifestyle, options that they may be able to, choose to help, address obesity. Next slide, please. Then when it comes to the social drivers as well, often they, begin in childhood and they can actually compound across the life course. So the research that I've been doing at Curtin has shown that, child maltreatment in the form of child neglect or child abuse is directly predictive of the development of obesity later in life. We also know that, you know, a dysfunctional sort of family home can, you know, really increase the risk of the development of obesity. And then during adolescence, you know, obviously that's a very sensitive time for, you know, changes in body image and how young adults and adolescents start to feel about the way that they look. And that can often be accompanied by a lot of bullying for those people that do, you know, maybe start to gain a bit of weight. That can then also be compounded by chronic stress during that time. And the really important point here as well is the development of weight stigma and weight bias in the broader community, and even in the context of healthcare, can really have a negative impact. And it becomes this sort of really pervasive effect on a person's life. If they've started to gain some weight and they start to experience weight stigma, then that can actually sort of develop this sort of negative feedback where the stigma actually feels into worse feelings about themselves. And then that can actually then perpetuate, say, further, you know, maladaptive behaviors around possibly, you know, turning to food to cope, which then can lead to greater weight gain and then often even more stigma as well. So the weight bias and stigma in our communities is really a barrier for many, many people, even if they, you know, are very much, you know, eager to possibly, you know, start thinking about lifestyle changes. Just the next slide too, please. So what happens when we combine the economic and the social drivers, you know, in combination? And this, you know, obviously I won't go through this model in a lot of depth now, but this model here by my colleague Eric Hemmingson, published in 2023, I think is a really good sort of life course model, really focusing on more of the social and the economic and psychological factors that can underlie a lot of people's experiences during life, which often can lead to the development of obesity, but are often ignored or completely unaddressed. So you can imagine here, if we start at part A, where someone may have experienced some sort of family and social adversity at the beginning of their life. And then if that then leads on to, you know, different types of insecurity, whether it's abuse or neglect in the home, if that's then compounded through different forms of chronic stress and anxiety, this is then, as we move through part B and then into part C of the model, it's where people may start to, you know, turn to possibly food or different ways of coping with all of that underlying social adversity and stress, which then can lead to, say, the development of overweight and maybe obesity and even higher levels of obesity. And then it's at the bottom of that model there in part C, often sort of during adolescence and early adulthood, where the weight stigma, the judgment, and all of the internalized stigma about themselves because they have gained weight can really then develop this negative feedback loop where the stigma feeds into negative perceptions of themselves, greater weight gain, greater stigma, and so on. So I think it's really, really important, particularly on World Obesity Day, that we really start to pay attention to some of these underlying social and economic factors that are really strong predictors of the development of obesity in our societies. Thank you.
Thank you so much for that, Blake. I'd like to introduce the next speaker. We have Professor Helen Skouteris.
Thank you. Thank you, Kimberly. Following on from Blake's fabulous presentation, I'll be talking to you today about weight stigma as a gendered issue, and I'm presenting the work of my senior research fellow who's pioneering this work, Dr. Bryony Hill. So next slide, please, Kimberly. We know that 3.3 million Australian women are vulnerable to weight stigma across preconception, pregnancy and postpartum. Women experience 3 weight stigmatising events per day on average, and we know that women experience weight stigma at almost every healthcare visit. Next slide, please, Kimberly. So why is weight stigma such a problem for reproductive aged women? The reproductive years can be a period of weight gain for a lot of women. Weight stigma is prevalent in healthcare settings, including preconception care, family planning and maternity care. Women experience weight stigma in everyday life, including education, employment and healthcare. The stress of stigmatisation can elicit adverse physiological, psychological and behavioural responses. The public health ramifications of weight stigma can have serious intergenerational implications. You can see there that the severity of this issue also culminates in an equity issue that we cannot ignore. Next slide, please. And so women's experiences also intersects with a stigma. The stigma affects both women living in a larger body and women classified as normal weight, important for women who self-perceive weight, stigma, weight bias, internalisation. Women express feeling hurt, judged, shamed, embarrassed, and humiliated. They are blamed as individually being responsible for their own weight and any issues that arise in pregnancy. And there are assumptions made towards them about their food, exercise habits, that they are lazy and lack self-control. So thank you for listening.
Thank you, Helen. I'd like to introduce the next speaker. We have Teresa Girolamo. Thank you.
Thank you, Kimberly, and thank you, Helen. That was very powerful, and I guess we see that in the primary care setting. So I'm going to primarily talk about addressing inequity in the primary care and the challenges we face in doing this. And I think primary care is and should continue to be the backbone of our healthcare system. I'm a general practitioner and I work solely now in weight management and metabolic health, just as a bit of background to me. So next slide, please. So I guess the first issue is actually identifying the problem and starting that conversation in the primary care setting. And we know, unfortunately, even though 2/3 of our population live with either overweight or obesity, in the primary care setting, only just over 22% of patients have a BMI recorded, and just over 4% have a waist circumference. And we know from the new Lancet Commission that we need to be measuring both of these parameters. In addition to that,
Teresa, sorry, can I just get you to speak a little bit closer into the microphone? It's just a bit hard to hear you.
absolutely. Sorry about that. Can you
Thank
hear
you.
me better now?
Yeah, a little bit. Yes,
A little
very
bit
quiet.
better? Okay, sorry about that. So less than 1% of GP consults centre around obesity, and so we need to change this. And we know that it's an average of 9 years between the time that an individual first struggles with their weight and when they first discuss it with their healthcare provider. And so what, I guess, are the barriers and challenges that we face here? Next slide, please. So we've already heard beautifully about the issues of weight stigma and weight bias, and unfortunately we as healthcare providers are amongst the biggest offenders in this area. And this can absolutely negatively impact patients' wellbeing and engagement with the healthcare system. Education is another big issue, particularly with general practitioners and primary healthcare providers. They need to understand the complexities of obesity and managing patients living with obesity. We need to have the education, the adequate training, adequate resources and referral pathways. Then we come to funding models. We know that Medicare provides inadequate remuneration for relevant service provision, given the complexity of care, of chronic health in general. And whilst I'm not political, we know that the bipartisan agreement of universal bulk billing, this will only provide us with greater challenges in the management of patients living with complex conditions, including obesity. And unfortunately, it fosters that rapid throughput of 6-minute medicine, and we cannot manage a patient adequately in this time frame. Clinic equipment and setup, we need to make sure we have appropriately rated seating, accessible areas in our clinics, the larger size blood pressure cuffs, bariatric scales. They're just amongst some of the equipment that is required so we don't perpetuate the stigma when patients come to see us. Then, of course, we've got interdisciplinary care, and we need to make sure we break down the silos and start working with a team. We need to find our tribe in our local area who are, individuals who are also interested and have the knowledge, the adequate knowledge to manage patients living with overweight or obesity. The cost of treatment. So we're very fortunate now that we have some very effective treatments, both pharmacotherapy and, of course, bariatric surgery are two of some of the more advanced and management strategies. Of course, we know that diet and exercise is the cornerstone to any program, but we do have other options, and some patients will have difficulty either losing weight or maintaining weight loss. Unfortunately, there's a great cost that comes with these treatments, and that just further challenges the inequity in the system. And then, of course, we've got the vulnerable communities, and we've already had some information about the challenges here. So remote communities, and we saw, I think from one of Tim's slides, the great disparity in the prevalence of obesity in certain communities. And Indigenous, culturally and linguistically diverse, and the disability sector. And we know that there is higher incidence of obesity and less access to care. And then, of course, the cost of treatments exacerbate these existing societal inequities. So thank you.
Thank you for that, Teresa. I'd like to introduce the next speaker. We have Associate Professor Sam Hocking.
Hello, everybody. Thanks for having me join today. And I'm specifically going to be speaking about access to specialised obesity services. And I'm sorry that I wasn't here to hear all the other speakers before me, because I've been working in a specialist obesity service clinic this morning and just finished seeing my last patient. So I've only just been able to log on the call just in time to speak. So as you've probably already heard this morning, and I heard Teresa allude to it, one of the issues for people living with obesity is that it unfortunately disproportionately affects those who have the lowest access to care and who can least afford care. And this is particularly pertinent when it comes to medical care for obesity, as we've just heard mentioned by Teresa. So one of the issues is that very few obesity treatments receive any form of government subsidy. Multidisciplinary care for obesity is obviously incredibly important. We need the involvement of an allied health team, including dietitians, exercise physiologists, psychologists, many other members of this team. There is a provision for some subsidy to access these services in primary care using a chronic disease management plan, but unfortunately this only provides a very small medical rebate of around $63 for only 5 allied health visits a year, and these visits cost an out-of-pocket cost on top of that, varying between $50 to $200 an appointment. So for people who are struggling financially, this is often out of reach. The other issue, of course, is access to medication. We're now very lucky to have 6 registered anti-obesity pharmacotherapies available in Australia, but again, none of these are subsidised through the pharmaceutical benefits scheme. And the cost for these medications ranges from $88 per month out of pocket to as much as $700 per month out of pocket. So again, at a very high cost to the person living with obesity without sufficient subsidy. When it comes to specialised obesity services, there are a number of specialised obesity services in public hospital clinics around Australia, but unfortunately, these are located only in major metropolitan centres. So for people who live in regional or remote areas, they're often out of reach. There's also a lot of variability in what is offered through these specialist obesity services. So not all of them have the allied health support that others do. And so there's some inequity then in access. Not all have access to bariatric surgery. One of the problems with such a limited number of specialist obesity clinics is that waiting lists to get into these clinics are very high. Often those waiting lists can be many years. And to try and limit the number of people who can come to the clinics, to limit the waiting lists, sometimes the entry criteria are very strict, which means that unfortunately people are only able to access these specialised obesity clinics when they become quite unwell and they're therefore quite end stage with their obesity before they're even able to access care. So I think this just highlights then the problem that Teresa's already pointed out in primary care. It's then compounded with this inability to access specialised tertiary obesity care. Now, I haven't said next slide because I think there was an issue with my slides uploading, but if you just try the next slide in case there is something there, I don't think there will be. No, and then finish and I'll hand over to Alex, who's going to talk about the bariatric surgery perspective. So thanks very much.
Thank you so much for that, Sam. We really appreciate it. I'd like to pass on to Alex Craven. Thank you.
Hi, everyone, and thanks for having me. It's an honour to be here. I'm joining you from the lands of the Wurundjeri people of the East Kulin Nation, where I'm proud to live and work. I am going to talk about metabolic or bariatric surgery, and this was a hard talk to prepare because I'm a proud Australian and I'm very proud to work in our public healthcare system. But when the theme is inequity, and being a doctor, a father, and a healthcare worker, I need to call out a very real, deliberate discrimination in our public hospital system against people with severe clinical obesity. Discrimination that's causing harm, disability, and death regularly. Obesity is a disease of genetic susceptibility, and it's present wherever populations have consistent access to food. Prevention and management is definitely getting better, but some people slip through the cracks due to factors well beyond their control. Some of those people have severe clinical obesity. This is where disabling or life-threatening diseases are caused directly by their obesity and are only managed effectively by effective treatment of their obesity. For many people with severe clinical obesity, metabolic or bariatric surgery is the most effective, life-saving, and cost-effective treatment available, and in other cases, it's simply the only sensible option. Despite all this, I'm sorry to say, despite overwhelming evidence of benefit and cost-effectiveness going back decades, access to this surgery is systematically and specifically denied in Australia's government-funded hospitals. Over 95% of Australian public hospitals simply refuse to provide this essential surgery. Many others are imposing arbitrary and unjustified restrictions on case numbers or resources. And this is despite metabolic surgery being a standard part of care for multiple medical conditions. By refusing to allow access to metabolic or bariatric surgery, our government-funded hospitals are actually failing to meet modern standards of care across a number of medical fields. The saddest part for me is there's absolutely no rational reason why it has to be this way. Metabolic or bariatric surgery in this country is funded in public hospitals no different to any other surgery type, and existing resources in most hospitals could support this starting tomorrow. Dedicated healthcare professionals in public hospitals around the country are desperate to provide this, but are repeatedly blocked by their administrations, simply based on stigma. Meanwhile, the same hospitals will spend taxpayer money and their patients' health on less effective, more costly treatments for the predictable and preventable complications that occur when we neglect to provide metabolic and bariatric surgery for people with severe clinical obesity. When most of the people seeking this treatment form are women, blocking it is discrimination by neglect. When First Nations people are overrepresented in those most at need and with the worst access, this is discrimination by neglect. When only a tiny percentage of our hospitals actually step up and provide this standard treatment for severe clinical obesity, when people need it, this is essentially a postcode lottery for the lives and health of Australian people. This isn't the only problem. It's not the solution to the be-all and end-all, but of all the problems we're going to hear about today, this is the one we can most easily fix and fast. It just requires the will to allocate existing resources fairly and based on clinical need rather than stigma and deliberate discrimination. All I'm asking for is people to call it out. If your hospital provides surgery for the complications of obesity, but not metabolic surgery for the biology of obesity, call it out for the bad and ineffective practice that it is. If you have influence on healthcare leadership and your institution is blocking access to this surgery, fix that. And if you work in the community healthcare and you're watching people develop disability and disease that could be avoided through lack of access locally, speak up. Demand better for your patients. And all of us talk to your MPs, let them know it's unacceptable that people are suffering and dying due to deliberate and systemic neglect of this one critical area of medicine in Australia. I'm going to finish with an apology because there's a lot of people out there living with severe clinical obesity who need this care and they cannot and will not be able to access it. On behalf of the Australian healthcare system, I'm sorry. I'm sorry our hospitals are letting you down. I'm sorry our hospitals are letting people die. It's not okay. We can and should do better. Thank you for your time.
Thank you, Alex. I'd like to pass on to Zainab Malik, our next presenter. Thank you.
Thanks, Kimberly. Thanks for having me this afternoon. I'm very privileged to be able to discuss the special dental needs of those living with clinically severe obesity, which is an often less discussed issue. Next slide, please. When we discuss bariatric dentistry or dentistry for people living with obesity, there's several key areas that this encompasses. So we look at clinical, service delivery, and patient-related implications of obesity. And given the increased risks of medical comorbidities linked to obesity, it's crucial that they have access to not only their medical services, but oral health care services. And this is additionally pertinent given the findings of cross-sectional studies involving people with clinically severe obesity have showed that they have high rates of poor dental attendance, dental anxiety, and poor oral health-related quality of life. Bariatric dentistry also accounts for the emerging evidence between obesity and dental diseases, like increased links between gum disease or periodontal disease and obesity. And the dental professional's role in the dental management of people living with obesity is also an emerging aspect. It may interest you to know that when patients exceed the safe dental chair weight limits, which typically sit around 140 kilograms, but this may be higher depending on the chair model, they require their dental treatment in a bariatric dental chair, an example of which we can see on the right, which can accommodate higher weight limits of up to 455 kilograms. Unfortunately, in Sydney, Australia, where I work, there are only 3 bariatric dental chairs to service a population of more than 230,000 people living with severe obesity. The situation is similar interstate. Individuals can currently require referral to public hospital-based special needs dentistry departments, where these bariatric dental chairs are located. And unfortunately, in turning patients away for their safety, dental professionals may engage in stigmatizing conversations, and this is one example of weight stigma in the dental setting. The key is that not everyone living with severe obesity requires specialist dental management, particularly if they present with stable medical conditions. But given this placement of the current bariatric dental chairs in dental specialist departments, patients are then forced to wait on long public waiting lists and ultimately may only require or receive emergency or needs-based dental care due to limited resources. And on World Obesity Day today, this is a great opportunity to bring attention to this ethical dilemma. Why should a patient find it difficult to receive preventive dental services like a scale and clean on the basis of their weight? And what happens if they're not eligible for public services? We need to be prepared with better solutions. Next slide, please. Previous qualitative research involving the perspectives of 40 individuals living with clinically severe obesity attending a tertiary metabolic health service confirmed a key barrier to accessing dental services was their experience of weight stigma. And this is sometimes even before they met the dental professional, which might have included their initial point of contact with support staff. People living with clinically severe obesity provided numerous suggestions to improve their dental access, including things like increased numbers of bariatric dental chairs, possibly within their medical obesity services, with privacy as a main feature to these facilities. They wanted dental professionals to increase their awareness and knowledge of obesity and provide kinder treatment and take measures to overcome their experience of weight stigma. Next slide, please. However, our scoping review outlined previous gaps in the literature. There were no interventions focusing on weight stigma reduction in the dental setting, and this is particularly needed, as well as continuing professional development in this area for both clinicians and support staff. We're now currently evaluating a weight stigma educational module among oral health therapy and dentistry students, and found it, whilst it was useful and relevant, it did not fully address issues of personal blame relating to the causes of obesity. So like in other healthcare settings, we will likely need multifaceted interventions to address the complex drivers of obesity stigma. Thank you for your attention.
Thank you for that. I'd like to introduce Professor Anna Peters, who has kindly offered us a video as well. Just press play.
Thanks very much for this invitation to speak at the World Obesity Day discussion on a topic that I'm very passionate about. Really look forward to spending a few minutes talking about how to improve equity in obesity. As many of you will be aware, a number of Australians live with much higher rates of overweight and obesity in a way that's associated with their sociocultural or socio-demographic background. These might be characteristics such as where people live. So we know that people living in remote areas of Australia have much higher rates of overweight and obesity. Similarly, people from some cultural and linguistically diverse backgrounds, people with greater financial constraints, we know that these structural challenges contribute to a higher risk of overweight and obesity, and then the chronic conditions that follow. And so my first take-home point is really that we're very clear this is not really about the individuals in those groups, it's about the common systemic structural barriers that they face for both obesity prevention and subsequent management. And these might be resource barriers like financial constraints, time constraints, health literacy, or even general literacy and language barriers. And there might be access barriers, things like for obesity treatment and management. How able are they to get the right treatment in the right place at the right time? What are the barriers that they face that are structural and systemic? There are a number of access barriers when it comes to healthy and affordable, culturally relevant food, and a number again when it comes to safe and appropriate physical activity options. And I really like this schema from Finnish physician Pekka Puschka, which I think Louise Bauer shared maybe 20 years ago, which really demonstrates this steep gradient that you're asking an individual to push the healthy weight ball up, which is all those major structural barriers to obesity treatment and prevention. And so it's clearly really important that these barriers are removed and that they're removed at scale, so that it's not about each individual having to tackle them. It's really a systemic approach that will allow us to remove those barriers at scale in a way that makes it much easier for all individuals, all Australians, to push that ball across a much less steep gradient. And so without going into lots of detail, because it's a very brief talk, I just wanted to outline, what do I mean by systems? And so if we just think briefly about treatment, access, constraints and barriers, the systems that drive that are things like our health system models, the extent to which they provide easy integration and appropriate and adequate funding, no matter who you are or where you are and what you need. One example of that is obviously the rural and regional infrastructure that exists is not optimal for allowing equal access to appropriate obesity treatment and management for people living in remote and regional areas. Similarly, if we think about healthy and affordable, culturally relevant food, there are a number of systems that really are not necessarily adequate or appropriate for all people. So food system policy, planning and infrastructure, transport and logistics, they are all systems that we could intervene upon to try and make sure that some of these major structural barriers to accessing healthy and affordable food are removed across the entire population. And similarly, if we think about physical activity, some of those systems, transport, facilities, we know planning laws contribute safety and the environment, heat, pollution, all these things impact an individual's capacity to partake in appropriate and safe physical activity through mechanisms that have got nothing to do with them as an individual. So I just want to end by really thinking about, well, how can we intervene on these systems? And, part of that is clearly a recognition of the first 2 points I've made, that the barriers are structural and systemic, and that we need to remove them in a way that recognises this. And I just want to end by saying there are a number of tools that exist to help for policymakers. There are a number of equity impact assessment tools, and a recent piece of work from one of our PhD students, I'll leave you with this schema, has really identified what is it that can enhance equity when we are planning for policy in a way that recognises all these structural barriers. So thank you very much.
Thank you so much for that, Anna. I would like to move on to Professor Rosemary Calder, who has also set us up a video as well.
Good afternoon, I'm Rosemary Calder. I lead the Australian Health Policy Collaboration at Victoria University. The AHPC, as we call it, is an informal network of Australia's experts that has been working together, supported by us, for more than 10 years now. And the focus is on improving prevention policy, prevention practices to reduce preventable chronic diseases in the Australian population. I'm talking to you about Getting Australia's Health on Track 2024, which is a signature publication of the AHPC and is a policy compendium focused on the evidence-based policies that we propose to government that will work if implemented. And we need to all use these resources to pursue that implementation. Let me show you why it matters. This is the data that we use in Australia's Health Tracker, a parallel publication. And in 2024, we looked at the rates of preventable chronic diseases in disadvantaged communities. And this is just 2 items of data from that report. One is the divergence in the rates of cancer in disadvantaged communities, increasing rates compared to decreasing rates in advantaged communities. The other, the increasing rates of diabetes in disadvantaged communities compared to the much slower increase in advantaged communities. And we all know that overweight, obesity is a significant contributor to both of these. Getting Australia's Health on Track 2024 proposes 4 policy objectives that I'll talk to you about in a minute. There are 10 policy actions for implementation now. So that's a shopping list of asks to politicians, to bureaucrats, to policymakers at Commonwealth and state levels. And if these were implemented now, we would see a considerable change in that data over the longer term, of course. So let me now talk to you about the policy objectives. 2 of them are not health, and we all focus generally on the health sector and health initiatives. But in disadvantaged communities, what we know is that the community is lacking in resources itself. And what we see now is a significant range of initiatives going in from Commonwealth, state, local government, from regional organisations like primary health networks, from not-for-profits, from philanthropy, and none of them work together. What now is happening is an overload of complexity and separation in disadvantaged communities. So we call for a national framework incorporating Commonwealth, state and local government with a national fund to support initiatives to achieve collaboration and working together in disadvantaged communities across the spectrum. We also call for healthier environments through urban planning. We currently have no health criterion in national and state and local planning provisions for residential or commercial developments or otherwise. That's an essential factor to improve our communities. Then we ask for the tailored health provision. Preventive health initiatives don't work in disadvantaged communities. We need to co-design them with those communities and implement them with and through the communities. And we need to address the financial and other barriers to access to high quality care in disadvantaged communities. I hope you'll look at this resource. There's the QR code for you to look at. Please come back to us if we can help you with your work, and please use these resources in your work. Thank you very much.
Thank you for that. And I'd like to pass on to Andrew Wilson. Thank you, Andrew.
Hello, I'd like to acknowledge the First Nations Darug and Gundagara people as the traditional owners of where I live, and acknowledge individual and collective expertise, those with a living or lived experience of obesity. Thanks for the invitation today to speak on World Obesity Day, and I'm happy again to claim my space as someone with lived experience of severe obesity. My name's Andrew Wilson, and I'm an advocacy and engagement lead of the Weight Issues Network, which is a peak body for lived experience of obesity in Australia. We've got a big problem with obesity. I don't need to go into it. Less than 4 minutes to talk. Read the National Obesity Strategy or Google obesity epidemic for more information. Obesity is a complex and nuanced chronic condition, as the recent Lancet Diabetes and Endocrinology Commission has uncovered. Thanks, Louise. We need to find more innovative and nuanced real-world solutions, not a one-size-fits-all approach to obesity. To do this, we need to include the voice of lived experience people in developing strategies to address obesity. Without this approach, we'll waste resources and further delay fixing a problem we are truly struggling to deal with right now. Okay, so some of the barriers of working with people living with obesity for research, as I see it. Firstly, many people are coming from a place of stigma and quite often also trauma. So not a great place to allow for meaningful communication and development of solutions. Unfortunately, this also limits the number of diversity of those who participate in research. Participants are often limited geographically to major cities, and many people who need help are socially isolated or self-isolating. Often in research, people who can afford to be that are representatives are represented, and those who can't aren't. As a result, we're not getting a good representation and not enough data to create effective solutions. Currently limited time to input studies and opportunities to digest information make meaningful contributions hard. Another barrier is significant proportion of our lived experience community are neurodiverse. There are ethical considerations working with people living with obesity. Do no harm. Quoting Lifeline number after you've asked somebody to dredge up traumatic life events is not good enough. Lastly, there's also the potential power imbalance between researchers and participants. And these are all considerations and potential barriers of working in this space. If I can get you to go to the next slide. Okay, that's the organisation I work for. And that slide, yes. So the WIN Digital Think Tank is an electronic platform. It allows diverse participants from different states, time zones, and remote areas to collaborate on projects on and offline, allowing people time to ponder questions and find solutions in their own time. Some of the best ideas come when we aren't in front of researchers. With the Digital Think Tank, input is available 24/7. For effective communication obesity, education and a supportive, safe place needs to be created. WIN has been working on this for the last 5+ years. People often started our meetings with their video turned off, due to weight stigma. And I can't tell you how happy it makes me feel when people become comfortable and, turn their screens on and then become very active in our groups, and many with amazing ideas. It's wonderful to see what comes from empowerment from people, riffing off ideas of people in a group meeting. Embedded in the Digital Think Tank is advocacy. We want to help the community. We've vested interest in it for our families and communities. We want to ensure that research leads to meaningful action and policy change. Lived experience research remains crucial for providing deep, nuanced understanding and solutions for people living with obesity. We have the framework. We've already started it. It's called the WIN Digital Think Tank. Please support WIN and the Obesity Collective to develop strategies to address obesity. And let's continue to fire up the National Obesity Strategy. And the last slide. Thank you for listening. And here's a link to the Weight Issues Network. Thank you.
Thank you, Andrew. I would like to introduce Dr. Catherine Williams now. Thank you, Catherine.
Thank you for the opportunity to present on designing better obesity care services to address inequity. I'm going to present this topic in the context of 3 men who were admitted to hospital last year, and obviously some details have been changed to protect identities. All of these men were admitted with something called obesity hyperventilation syndrome, which is where the body, or particularly the brain, loses the ability to breathe properly, and we get drops in oxygen and very dangerous rises in carbon dioxide. Max, age 22, as you can see, had a BMI of 85 and had a hospital stay of 2 days. Mark, age 42, with a BMI of 75, had a hospital stay of 45 days. And Matt, age 52, with a BMI of 105, had a hospital stay of 20 days. Now, all of these men reported obesity in adolescence and adulthood, and Mark, in fact, had a weight of 160 kilos at the end of primary school, but none of them received treatment. Max and Mark are both unemployed, and Matt is on a disability support pension. Max and Mark live in the dead zone of Western Sydney, so they have no access to public transport and there are no local shops. And Matt lives in a rural area and therefore obviously has no access to public transport either. All men stay at home due to their inability to walk more than 20 metres due to shortness of breath, and Max is very concerned about going out in public and being seen. All live with one family member. Max, 22's mother, however, works full-time and he has no supports during the day. Mark is able to call on a cousin for both emotional and physical support, and Matt's actually quite well connected from a family and a friend point of view. Max and Mark both have history of complex trauma and mental health, and Matt has claustrophobia. So on discharge from hospital, all of these men were given access to in-home nursing support services, a follow-up with the multidisciplinary obesity service with virtual appointments and subsidised obesity medications. Now we're going to move to the current day. 2 of these men did very, very well and 1 of them did not. I wonder if you could pick which factor was the determining factor as to whether they did well or not. Well, in these cases, it was not their age or their body mass index or their mental health diagnosis specifically, but it was their social supports. Matt and Mark have both lost 100 kilos and 30 kilos respectively with the obesity modifying medications. They're off oxygen therapy and can now walk more than 500 metres and are presenting to a clinic in person. They're both socially more engaged and Mark is attending TAFE looking for work. But finally, Max, age 22, unfortunately, he self-ceased his medications and had multiple no-shows to the obesity service and was lost to follow-up. A month later, he fell and fractured his hip from a standing height. This is the sort of injury you'd expect in an 80-year-old female rather than someone who's age 22. Unfortunately, he was admitted to hospital and 150 days later, he is still there. He can only walk 10 metres and he's oxygen dependent. And his base bed day cost would be more than $100,000. Next slide. So in the context, I just want to make 3 points related to these stories. So first of all, very severe obesity is not rare, especially in areas with high obesity rates like in Greater Western Sydney and so South Australia and Queensland, as we've heard. And it is linked to social determinants of health and geographical remoteness. Second point, we're missing opportunities to treat severe obesity by not recognising the seriousness or the cost of this condition for individuals and for health systems. And finally, the care for complex obesity can make a difference to the individual and to health services, but it needs to be tailored and collaborative. And most importantly, we need to understand a person's social supports and respond to these. Next slide. So how do we improve the appropriateness, effectiveness, and reach of our obesity services to manage people living with severe obesity? Now, I think previous speakers have already talked about the need to improve access to multidisciplinary obesity services, as less than 1% of our population with severe obesity actually can access them. Also providing those services with effective tools, and that means subsidised obesity modifying medications and bariatric surgery, and they can make life-changing differences in the sort of people that we're seeing in our services. Integrated care really needs to be beefed up with clear communication and role delineation so we can start sharing care effectively and also step up and step down strategies. Virtual care has a real role to support with on-demand content, live groups and coach clinicians that can help people work through that content. And last but not least by any means, we need the capacity to address social as well as health and medical issues concomitantly and mental health issues concomitantly. And the social issues are so important. And this can be done, for example, through peer-led and community supports and definitely in-home supports, particularly around disability, social services and hospital in the home, for example. And the last point I'd like to make is that geographical co-location of these components is not necessary for this work. And so rural and regional areas can be better services if we're more connected in the way we work. Thank you.
Thank you, Catherine, for that. I'd like to introduce the next speaker, Ms. Judy Neen. Thank you, Judy. Oh, you're on mute. There you go. Thank you.
Thank you, Kimberly. I'm the Senior Director at Health and Wellbeing Queensland, the Queensland's state prevention agency, and it's a pleasure to present today on World Obesity Day. I acknowledge the traditional owners and the custodians of the lands across Australia, and I'm on Jagera and Turrbal lands. Next slide, please. In May 2024, Making Healthy Happen 2032 was endorsed as the Queensland Government's strategic response to the National Obesity Strategy. Our strategy adopts the 3 ambitions of the National Obesity Strategy, ensuring a whole of government approach to supporting health and wellbeing across the population. Making Healthy Happen is driving 40 actions in our first action plan over the next 2 years, led by 11 Queensland government agencies working collaboratively across sectors to turn strategy into impact across the 3 ambitions, namely creating supportive environments by leading cross-government efforts to reshape systems that influence health, empowering people and communities through supporting local solutions and promoting health and wellbeing across the lifespan, and strengthening healthcare by expanding prevention, early intervention and access to supportive healthcare services. Next slide, please. Through Making Healthy Happen, we're embedding prevention and equity into policy, systems and communities. As we all know, health is shaped by the environments we live in and the opportunities we have. That's why we're focused on changing systems, not just behaviours, ensuring all Queenslanders have the conditions they need to thrive. Under creating healthier environments, we're making schools, workplaces, hospitals and communities healthier places to live, work and play. We're empowering people through community-led solutions and leadership, and we're strengthening prevention in the healthcare system. We are also promoting supportive and inclusive conversations about health and weight, reducing stigma and shifting the focus to system change. And those programs that you see on the slide there are just some of the actions we have underway in Queensland. I'll just talk to a few of those. Pick of the crop. We have engaged more than 225 schools and more than 49,000 students in our healthy eating program that is really encouraging a connection with local growers and farmers to support and encourage schools and their kids to eat more fruit and vegetables. 17,000 families have engaged with our wellbeing app called Pod Squad, which has a focus on creating healthy habits for families with young children to focus on healthy eating, moving and sleep. Our A Better Choice initiative has seen more than 94% of vending machines in all of our 16 hospital and health services now free from sugary drinks. More than 20,000 Aboriginal and Torres Strait Islander people have engaged with the Deadly Choices program, which is delivered by the Institute for Urban Indigenous Health, encouraging Aboriginal and Torres Strait Islander people to make healthier choices for themselves and their families. And 687,000 people have tracked more than 430 billion steps from the 10,000 Steps program, supporting and encouraging daily movement. These are just some examples of prevention and action that are being driven by strong government collaboration and partnership at the community level. Next slide, please. Health and wellbeing starts where people live, work and play, and that's why we partner directly with local governments and communities to co-design practical, place-based solutions that create real lasting change. Here are 3 examples of our work in action. In Bundaberg, the Do You Thing initiative is a partnership between Health and Wellbeing Queensland and the Bundaberg Regional Council and the Department of Tourism and Sport. This project has been going for over 4 years, and over the last year, we have seen very strong engagement by 89 stakeholders and local health and wellbeing providers across the region, delivering 354 activities to more than 7,000 community members. Wellness My Way is a partnership we have with the South West Hospital and Health Service and the Health Contact Centre in Queensland, piloting a new consumer-facing model of care that directs adults to an online health check, and then it provides a health coaching session for people to develop an action plan based on their health goals. So just over the last 9 months, we've had 290 people in the Southwest, in the areas of Roma and surrounds. So that's about 6 to 10 hours southwest of Brisbane. 290 people have completed the digital health check, and 119 have gone on to complete the model and engage in the health coaching. We are linking people through that program to local, state and national prevention programs, and there have been more than 164 referrals made. And then thirdly, we have had a strong emphasis on working actively with local councils, and we're currently engaged with 27 local councils across Queensland to support the health and wellbeing of their communities. And 22 of those local councils are specifically supporting a priority on Aboriginal and Torres Strait Islander peoples. We have an MOU with Cookshire Council that is focused on this, and we're in the final stages of finalising an MOU with Gold Coast to strengthen local action there. All of these partnerships are embedding prevention into everyday life and ensuring it's led by the people who know their communities best. Thank you for your time.
Thank you, Judy. I'd like to now pass to Professor Louise Bauer. Thank you.
Hello. Hello, everyone. I'm going to talk about how the proposed new definition of clinical obesity might help address inequity of care. Next slide, please. The Lancet Commission on the Definition and Diagnostic Criteria for Clinical Obesity was published in January 2025, just a few weeks ago. This, while it took quite a while to come together, it sought to define clinical obesity as a condition of illness that directly results from the effect of excess body fat on the function of organs and tissues. So rather than defining obesity in terms of other health problems, there were 58 experts from multiple countries, including people with lived experience, who participated in a consensus development process over a long period of time. The key elements I want to highlight, it was not just BMI, while BMI is a useful screening tool, but things such as body fat and fat distribution are really important in terms of health risk. And then the other issue was, are there health problems specifically linked to excess body fat? Next slide, please. To highlight the differences between clinical obesity and preclinical obesity, you can see image there of Jack and of Maria. Both of them have the same BMI, but Jack, who we would see as having clinical obesity, has excess body fat with alterations in organ function and tissues and or problems with activities of daily living. And you can see here, in this case, he had obesity-related some early heart failure, and he also had shortness of breath and many other health issues. In contrast, Maria has excess body fat, yes, but with preserved function of other organs and tissues. She is, of course, at increased risk of developing clinical obesity and other health problems down the track, and so monitoring and support of her long term will be different, but the way you might start in terms of interacting with them may be different. It is, of course, on a continuum between preclinical obesity and clinical obesity, just as with diabetes. It's not a staging system. There is a role for staging systems, but this is not it. And there are implications for approaches to management and to prevention in clinical practice. And I just want to highlight that some people with preclinical obesity who have higher risk may benefit from more intensive clinical intervention. Those are some of the things that have been a bit confusing for people. Now, if we go to the last slide, I'll just reflect a bit on how the proposed definition might help address inequity of care. I think it's important. One of the ideas behind this was that recognition of clinical obesity as a chronic disease emphasises illness rather than potentially variable health risk, and may help, therefore, improve the legitimacy, which we should never have actually had to prove, of the importance of actually treating clinical obesity in a healthcare system. Secondly, there are no assumptions made about the health of people with high BMI. Clinical assessment is really important. It's not just the BMI that's important, and should be provided for all who seek it. The recognition of obesity of clinical obesity should aid a better understanding of the biological underpinnings of obesity, which lead to other health problems, and should help prioritise access to evidence-based therapy for those who need it. This is only a brief overview of this, and I encourage people to look at the infographics and the actual online Lancet Diabetes and Endocrinology report. Thank you.
Thank you, Louise. We've just had a few questions in the Q&A box. Most of our panelists have already answered these as well. Some of the topics were around the impact of trauma in early childhood, the need for more sustained services to deal with chronic issues around obesity, and gender issues in weight stigma as well, with lots of discussion on inequity. So thank you so much for all of the panelists who have answered those questions. I will pass over to Tim Gill now, just to finalise the webinar. Thanks, Tim.
Thanks, Kimberly. Apologies to everyone again for the delays in starting. But hopefully what you've heard today is some real challenges put out for the effective management and prevention of obesity, and particularly around the services that, some of the barriers through the provision of services or inadequate services in this particular area. We've seen and heard during this webinar about particular issues for First Nations people, for economically and geographically disadvantaged communities. We've heard particularly about specific women's health issues and the need to focus on some of the specific gender issues around these things. And in some ways, it is encouraging that some of these issues are reflected in existing government policy, and we've certainly heard there from Judy about what's happening in Queensland. And we've heard from the existing federal government and hopefully from the opposition that these are some of the issues that they're intending to address, although we have waited quite some time for those things to happen. We've also learned some lessons, hopefully, and particularly the strongest lesson I took away from today's webinar is that we really need to be engaged and listen to the lived experience voice, and to be engaged and listen directly to communities where there's this greatest level of inequities. And particularly to look at how we can better deliver services and preventive care within those communities. So the objective that we have up there within the Obesity Collective, I'm hoping that everyone can agree with and will join us in hopefully helping to achieve. And that is that we want everyone, regardless of their SES status, race, ethnicity, or geographic location, to have equal access to effective strategies and interventions to prevent obesity and receive quality care when managing obesity, but also that we address the systemic barriers that lead to the disparities in weight-related health outcomes. And as a result of this webinar and based on the talks that you heard presented today, the collective will be producing a short report, which will hopefully lead to some forms of recommendations on how to improve this situation. And so we would welcome input from anyone who has specific interests or expertise that they would like to contribute in this area. If you're not sure about the collective, then log on to the Obesity Collective website. We'd love for you to join us and particularly join in our efforts to reduce inequities that surround obesity. So thanks everyone for attending, and back to you, Kimberly.
Thank you, Tim. That concludes our Obesity Collective webinar in honour of World Obesity Day 2025. I'd like to express a special thanks to our speakers for sharing your expertise today and to all of you for your thoughtful questions and participation. We hope you found today's session valuable and inspiring. If you do have any further questions, please feel free to contact the Obesity Collective. We would love to hear from you. But thank you, everyone. Have a lovely day and see you next year for World Obesity Day 2026. Thank you.